Today we're going to talk about habit-based interventions on Alimentosyemociones podcast with Dr Rebbeca Beeken. Becca is an associate professor at the University of Leeds, supported by a Yorkshire Cancer Research University Academic Fellowship. Her academic background is in behavioral science and health psychology, and her primary research interest is in behavior change for cancer prevention and control. Becca completed her PhD at the University of Sheffield, where she was awarded an ESRC 1+3 studentship to explore the variables that impact health-related quality of life in cancer patients who have undergone hematopoietic stem cell transplants. Upon completion of her PhD, she was appointed to a postdoctoral position with the late Professor Jane Wardle at University College London, working across several projects related to cancer prevention with a focus on obesity and weight management interventions. These included a pilot trial of a weight management intervention for people with intellectual disabilities, a randomized control trial known as the Top 10 Tips, and a program of work exploring the impact of weight loss on cancer risk and the health behaviors in people living with and beyond cancer. During this time, she was also seconded by the MRC as a clinical trials coordinator and research design service advisor. Becca joined the University of Leeds in 2017 as a Yorkshire Cancer Research University Academic Fellow focusing on behaviour change for cancer prevention. She was awarded an Australian Endeavour Award to spend 6 months as a visiting senior research fellow at the Centre for Research in Evidence-Based Practice at Bond University in Australia, and she holds an honorary contract with the Department of Behavioural Science and Health at University College London. I just want to say that when we taped this episode, we thought we were going to have other guests on the podcast. Philippa Lally has given a great introduction to habits on the previous episode, so don't forget to see it on YouTube or listen to it on your favorite podcast platform, such as Spotify or iTunes. We have had to change the sequence of the episodes, but I am sure if you find appetite and weight management intervention an interesting subject, you will get so much from these episodes. Please don't forget to share, to subscribe to Alimentosyemociones podcast, leave a comment and press the notification button. Help us grow this channel. Hello everyone and welcome again to Alimentosyemociones podcast. Thank you for coming back, for returning, another week. And we have today a really important guest for me, and because Becca was my primary supervisor of my PhD, so I'm really happy to have you here, Becca. Welcome, Becca.
Well, thank you so much for having me, Claudia. It's a real pleasure to be here and to see you after having worked with you for so long. It's wonderful that we're still working together and still
and still are, which is really exciting. So that's really good. Anyway, we're going to talk about all sorts of topics, sort of habit related and habit-based interventions, and see where this takes us. And so I want to sort of start off sort of asking you, as a behavioral scientist, Becca, how on earth did you get into this area?
That's a very good question, Claudia. So I think probably like a lot of people you've spoken to, the very impressive and wonderful Jane Wardle is a lot to blame for the fact that I've ended up in this area, or to be awarded the credit for it. So I actually started in a different place. So my PhD, which I did at Sheffield, was looking more at how people cope after treatment for cancer, and particularly hematological stem cell transplants which is quite a significant treatment, and it was looking at the different ways that people adapt to that. And that was really interesting, and I enjoyed it. But I think at the end I wanted to sort of explore some different research areas and just work out exactly where I wanted to be, I guess, and make sure that I was in the right area. And I was lucky enough to get a post with Jane Wardle at UCL in what was the Health Behaviour Research Centre, and it was initially a role that was sort of described as Jane's helper. It was actually maternity cover for Gina Whitaker, who was in that role at the time, and the helper role just meant doing lots of different things on lots of different projects, whatever Jane needed you to do across her, impressive research portfolio. And it was a wonderful role in terms of, working very closely with Jane, and getting to do exactly what I'd wanted in terms of trying out, she worked across energy balance and cancer screening and communication. And so there were lots of different things to sort of dip my toes into and see what those different research areas were like. And then fortunately for me, Jane liked me. and so at the end of that maternity cover, an opportunity came up to work with Jane on a single study, which was on a big trial essentially, which was the 10 Top Tips trial, which was looking at testing a habit-based intervention for people affected by overweight and obesity in primary care. And so I had really enjoyed the work that I'd done with Jane in that role on the obesity side of things. I liked the idea of understanding better how we can support people to change their behaviours. So not just looking at how they cope, but how we can support them, in terms of improving behaviours and well-being. And I also was really interested in this idea of that something very simple. So the 10 Top Tips intervention was a leaflet intervention, could be used to support people in this way, and be particularly effective because it drew on this concept of habits and what that means. So yes, that was how I got into it.
That's a really interesting way of starting, with the work, but pretty much as sort of like you still carry out basically. So what are the top 10 tips, and what are they, and then how did you do the intervention, the trial?
So the tips themselves, I don't know that I can remember all 10 off the top of my head. I might have to remind myself of them.
It might help.
But I think they themselves aren't the key bit of the intervention. So the key bit is this idea that it's based on habit. So, but what I really liked about this work, and the work I continue to do, is the sort of applied side of it. So I really like putting things into practice and seeing if they work in different settings. So as I said, the 10 Top Tips was a leaflet, and it had 10 behaviours that together would, if someone went from doing all of them, from doing none of them to doing all of them, would result in a certain amount of sort of calorie deficit in their everyday life. So it's things like caution with your portions. There's one about 10,000 steps a day, thinking about your drinks. Very sensible
of the food, not being sedentary. Anyway, I'll put the link. I'll put the link to the tips at the bottom so that people can actually find them on the weight concern.
Yeah. But they were essentially very simple, things that some of them people would have been doing already, some of them they might not have been. But as I said, the key thing was this idea that you take these simple behaviors and turn them into habits. So there was, in the leaflet as well as the tips, there was this information about how you can do that. finding a consistent context or cues that will prompt you to do those behaviors, and repeatedly doing those behaviors in that context, that they become more and more automatic and you form a habit. And there was also a logbook so that people could track how they were getting on with forming the habits in the first instance. So it encouraged them to plan, to self-monitor, and to review and see how they were doing. So promoting sort of self-regulation in while you were trying to form those habits.
Yeah.
And it was based on work by Pippa Lally. So Pippa Lally is a brilliant habit researcher who, again, I still have the pleasure of working with. So she now works on the Ascot study with me, as well as another study. And she worked on the 10 top tips as part of her PhD, and she did some really interesting work looking at sort of how long it takes people to form habits. And the first study really that showed you could, we talk about habits a lot when we talk about diet and physical activity, but it's very rarely our interventions based formally on habit formation theory. And so her study was, again, sort of taking simple behaviors like eating an apple with lunch, or drinking a glass of water every morning with breakfast, or doing sit-ups, after your morning coffee. Ask people to do it every day in that consistent context, and to rate whether they'd done it and how automatic it became. And she showed that, yes, people essentially reported those behaviors as they did them more and more in that context to become more automatic, until they sort of plateaued, and at which point it was said they'd formed a habit. So the 10 top tips was off the back of that sort of very initial research by Pippa, and she was involved in the development of the 10 top tips, as well as the charities Weight Concern and Cancer Research UK. And then my involvement was quite late in the day in terms of just taking this intervention that they'd developed, and seeing whether we could actually work with healthcare professionals and teach them to deliver it to patients in primary care, so in general practice, and whether that would have an impact on those patients' weight. So yeah.
I mean, but you did this work, it was like, throughout the was it the UK or just England? I can't remember. Throughout the UK.
It was,
yeah.
No, it was England.
Right,
yeah.
England.
So we had it was a number of 14 practices across England, and we randomized just over 530 participants to have either the 10 top tips or the practice's usual care. One of the tricky things with this study, which, as you know, Cardia, research does not always go quite to plan, was that at the time that it was designed, that very little was being done in primary care for supporting people to manage their weight. And as you also know, research can take a long time. So in the time between sort of the initial design of the study to us starting to roll it out, and participants were in the study for 2 years, so it was quite a long time.
Yeah.
There were changes happening in the UK that meant the usual care offered at some of our practices became a lot more intensive. So they weren't, I think when it was initially designed, people got nothing.
Or a little sheet of paper with like some food sort of recommendations, or
maybe the Eat Well guide, or just it might just have been eat a bit less, move a bit more, but not very much. Whereas there was a change in it during the time, as I say, from when it was initially designed to when we were rolling it out. And so some practices that had by that point started referring to Weight Watchers, for example, which is obviously a much more of a program, intensive program.
Because I think that it's important to say, sorry, Becca, just that Jane always had this this philosophy that I always find so amazing, and try and carry forward, which is like like with her questionnaires, they have to be available for people. You can't charge for them. They have to be, or with the intervention, it was always her. I always got this feeling that the top 10 tips is like, it has to be something simple so that it can reach a lot of people, and so that it can be done, and that it's not going to cost that much money. And I know the intervention costs a lot of money to do, but if you follow the tips and were able to sort of self-monitor and check and and learn how to self-regulate, then essentially you're doing it in a sort of cheaper way than you would otherwise. Am I right?
Yeah, I mean, I think that was a huge thing for Jane. It was one of the reasons behind setting up the charity Weight Concern, was to try and promote the dissemination of some of the evidence that was being developed through research into weight management and obesity. And the charity was set up to try and ensure that was being disseminated to the public, and also to help get evidence-based programs into the public arena. So 10 Top Tips was one of those, but Shape Up was the other big one, which was a more intensive program, but was one of the first programs that sort of considered the psychological aspects of food or anything as within the program. But that was developed to either be a group-based intervention or a self-management intervention. Again, I think Jane always had in mind the idea that trying to reach as many people as possible, and I think, and that was the thinking with the 10 Top Tips, is it's a very brief intervention. It's not expensive. It takes a little bit of time we designed it so that it could be introduced by a healthcare professional in sort of 15 to 30 minutes to patients, and then that's it, compared to programs where patients have to go in every week for 12 weeks to see someone, if they either be a dietitian or if it's Weight Watchers, a group program. So it was designed to be sort of affordable, but also part of the benefit of that approach is that for the participants, if they don't have a lot of time, if they haven't got a lifestyle in which they can fit in going to an appointment at the same time every week for an hour, then because they've got a job that won't allow that, or they've got family commitments, etc., the 10 Top Tips was designed to be more easily fit in to everyday life, and not everyone likes group programs. So again, it might not be for everyone. I think there are individual differences, and for some people it may not be enough support, but for a lot of people it may, certainly the results from the trial suggested it did help some people. So it may be sufficient.
So you saw weight loss between the.
We did.
Yeah.
And we saw weight loss in the group that received the 10 Top Tips, and so we followed people up at 3 months, 12 months, and 24 months, and at 3 months there was a significant difference between those who'd received the 10 Top Tips versus those who'd received usual care. At 2 years, the people who'd received the 10 Top Tips had maintained that weight loss, but the usual care group had also, in that time, lost a similar amount. Which may reflect, as I mentioned earlier, the fact that people have started to get referrals to more intensive weight management programs. May also reflect that, if you sign up to a trial ask for support with you managing your weight, you're clearly quite motivated to begin with, and so if in 2 years you're not getting something, you may have gone looking for something. But I think it's still really positive that those who received 10 Top Tips lost weight and kept it off for 2 years, which suggests that they may have formed habits and stuck to those behaviors, because we, in addition to weight loss being really difficult, weight loss maintenance is notoriously difficult. So
yeah. No, I love the top 10 tips trial. It's it's really interesting, and Natalie came on as well, and she'll be talking about her work that she did as well with
another of my PhD students. But she did some...
you busy.
It's been a pleasure. But again, and
mention what she did, because that's what she did with that same top 10, and then she'll talk more about it.
So do you want me to mention it, or
just mention what she did, and then that way she can then talk about it.
So she did some really exciting analyses which were looking at, so obviously with interventions, you, as a behavioral scientist, you have these mechanisms of action that you think this is what you're targeting, and this is why you think it will work, because it's in the 10 top tips. Case the 10 top tips, you think it's going to help people form habits, and that's why they'll lose weight. But very rarely do people test. I think it's becoming, it's people are doing it more now, but often you don't test that. You just say, did it work or didn't it? And so Natalie looked at, for the 10 top tips, whether it worked because people had increased their automaticity scores for these behaviors. So had it helped them form habits, and did that explain some of the differences in weight loss at 3 months? And she also, Natalie's also really interested in self-regulation, and I'm sure she'll talk a lot about that
she will
next time. But so because during the habit formation phase, so once behaviors become automatic, the idea is you don't really have to think about them, but in the period where you're trying to form the habit, you do have to think about it a bit. And so hence, as I said before, we had those logbooks where people planned and monitored to see how they were getting on, and all of that is about increasing people's sort of self-regulation skills, and helping with that. And so you need that to form the habits. So you need to be self-regulating to help that initial. And so Natalie looked at both self-regulation and automaticity to see whether those two things explained the weight loss at 3 months, or the difference in weight loss. And indeed it did, which was brilliant. So she found that the differences in weight loss between the group who'd had the 10 top tips and those who hadn't were in part explained by increases in automaticity, or bigger increases in automaticity in the 10 top tips group, and bigger increases in their self-regulatory skills. So that was really exciting, and suggests that it's working how we think it's working.
No, I mean, obviously she'll explain more about this. Now, what about, I don't know, do you want to say anything else about the top 10 tips, or should we move on to the work that you're doing on ASCA? And
I mean, I guess the other thing I could say now is, if we're talking about Natalie, I can say that we're doing this with the and Natalie's also kept up her interest in habits, and again, like you, I've been very lucky to continue to work with her since she's left UCL and the UK. So she's now, or she was at the International Agency for Research on Cancer, and with Mark Gunter and some others based there, they've been awarded funding by the French National Cancer Institute to look at supporting people who are attending bowel cancer screening to change their health behaviours to bring them more in line with what the World Cancer Research Fund recommends. And again, the intervention that they've developed is using this model, the habit model, within the materials that they're providing to participants. So that's really
brilliant.
exciting.
Yeah, that is
yeah.
really good. I'm sure she'll, be able to to expand on that.
It's a study that has been hard hit by COVID, I'd say, because it was just about to sort of get off the ground when COVID hit, and obviously attendance at cancer screening has been affected by COVID, but we're still going with it, and I'm sure she'll tell you more about it.
Yeah. Is this where you talk about teachable moments, or have I got it wrong and we use the asker?
Actually, you're right. Yeah, good question. So the other thing
and what
mention
does
about
that mean, because it might be very familiar to you, but probably not to a lot of the listeners.
So the other thing to say about that intervention, so it's based on habit theory, but the other sort of model of behavior, I guess, or that Natalie's brought into it, is this idea of teachable moments, which is the concept that at certain times people might be more receptive to receiving advice about changing their behaviors, and or then actually engaging in trying to change their behaviors. And there's a particular model called the Mcbride model of teachable moments, which suggests that when certain things happen, like cancer diagnosis or cancer screening has also been described as a potential teachable moment, people have an emotional response. So they might be feeling a bit more worried about their cancer risk. They might be or they might contrastingly be feeling quite positive about doing something about their cancer risk.
Is it within, is it within the health belief model? Is it part of it, or is it just
It's not, but there is overlap. Because outcome expectancies is another thing that comes into it. So thinking that in doing, that it makes them think that doing this thing will actually make a difference, to outcomes. And then there's some stuff around identity as well, so all of these things, the idea that you have an emotional response, and it might change your perceived risk as well, as well as thinking doing something will make a difference, and it increases your motivation and self-efficacy and leads to behavior change. So there's a lot of overlap with other models of behavior. And teachable moment as a concept has also been, I think there's some debate as to how appropriate that term is, because it sort of gives an idea, a sense of power, a power differential between the person giving the advice and the person receiving it. And I think there's an idea that it may be more of a two-way. So what actually happens at cancer screening is that it provides an opportunity for the healthcare professional to give that information, as well as for the patient to receive it. So it's not just about patient being ready to be taught, it's that the two together, it creates an opportunity for a conversation to happen.
So more like a sort of motivational interview, sort of like if you like, horizontal dialogue between the two?
I think it's just about the opportunity. If you thinking again of another model, I'm giving a bit of model overload.
Geek out.
So the combi model is obviously a really
great, wonderful,
really popular model, which talks about capability, opportunity, and motivation being the three key things that need to be in place for behavior change to happen. And if you think about giving advice on healthy eating, for example, that involves not just, so giving the advice is the healthcare professional needing to change their behavior if they're not doing that already, which a lot of healthcare professionals don't. And so if you give them something like the 10 tips or the intervention that Natalie's developing for the French National Screening Programme, and give them some training around talking to participants, etc., that might be increasing their capability to deliver advice. But equally, having a time where they're scheduled to see the participant that they're not having to organize themselves, that's creating an opportunity for them to do that. Equally, having those materials on their desk, will also perhaps not, that's also giving the opportunity, etc. So
or also increasing the motivation as well to change the behavior. No, good, nice geeking out them. I love the combi model, really love it.
It's been, even, I don't know whether you've seen, but certainly in the UK, it's sort of been in the news with the COVID behaviours around sort of COVID-19, etc. as well. So
it's really interesting, but like the main sort of nutrition book as well, which talks about different behavior change models, the main ones, like the health belief or the social cognitive theories, Bandura and all that sort of stuff, or has actually now introduced the combi model. So in Krauss nutrition, it's really good to see it. It's like, yay, it made it to Krauss. So I actually do a lot of teaching with it as well. So I like it a lot. So good.
I think again, it's one of those models that it's not overly complex, and it makes sense, and hopefully is helpful. I think I talk to medical students about it, and I think that they get it.
They respond. It is. It does make sense actually, and that I'll get someone to talk about specifically on the podcast. see if I can get Susan Mickey to come on the podcast. That'd be good.
That would be great. So Natalie's intervention is so it uses habit theory, but it's also based on this idea that screening might be a particularly good time to try and deliver interventions like this, because it's a time when patients who might not normally have an interaction with a healthcare professional might see them, but also it is a time where patients might be feeling a bit more motivated, or they're thinking about their cancer risk. And we've done some work. Claire Stevens did a lot of work sort of looking at whether people would want advice about different behaviours at different cancer screenings, and the majority did. And then she also did some really nice qualitative work that hasn't been published yet, but sort of exploring people who'd just been to screening, and asking them about whether they would have wanted advice. It was about physical activity specifically that she was asking, and that was really interesting, because it really highlighted that one size doesn't tend to fit all, and that there are individual differences. And although a lot of people were very positive about it, there were sort of 4 key types of people. So typology 1 was they had a negative sort of response to the whole screening process. It made them quite anxious. They were quite, they felt like they might be at heightened risk, and they were worried about the result. But actually, that made them want to receive advice about physical activity, and they wanted to be able to do something that might reduce their cancer risk in the future. But then there was another group who had a similar sort of negative response to cancer screening, were very worried, etc., etc. And they definitely didn't want advice, because they felt like it was too much, and it would just be, I think they said, it's bad enough as it is. I don't want to be being told what I'm not doing at that sort of time. And they weren't completely against getting that advice later down the line when they'd sort of been told that everything was okay. But they said if someone started talking to them about things they could do to reduce their risk at the appointment, they might start thinking something was definitely wrong. Whereas the other group wanted it at the appointment. So And then another group who didn't have a negative response and just, felt like it was a really good thing to be doing. And if they got advice about more things they could be doing, that would be great. And then there was another group who, they didn't really have a strong, it wasn't really related to their response to the screening appointment itself. It was more, it just very much would depend on how that advice was given, which, I think is so important, in whatever context, that we don't want to be acting judgmental or, lecturing our patients about what they should and shouldn't be doing. It's very much about having conversations about, supporting them to do what they want to do to feel better, and in this case reduce their risk of cancer was the focus, but whatever it might be.
Wow.
Yeah, that was really interesting.
I'll get Claire on as well.
Yeah.
To talk about that. What about the ASCOT work that you've been working on? I mean, that's been quite ongoing and has had sort of different phases, no?
Yes, this is a really big trial, which is very exciting. I lead with a colleague, Dr. Abby Fisher, and which Pippa Lally, who I mentioned earlier, is also our excellent trial manager on. She's keeps everything going. And
what does it stand for? ASCOT.
Advancing Survivorship Cancer Outcomes Trial.
Right.
And again, this was work that started off with Jane and was particularly exciting for me because I felt like it brought together sort of the work I'd done in the past in my PhD. So I mentioned like working with, looking at how people coped after a diagnosis of cancer. And then I moved into, this habit-based intervention in primary care that was more on the prevention side of things. And then with a lot of the work that I do now, it's still looking at interventions to support dietary and physical activity behavior change, often using the habit model, but for people who've had a diagnosis of cancer. So it's supporting them to cope, but using, but targeting, diet and physical activity changes to help with that, because there's, a huge amount of evidence now that these things are important for cancer outcomes, and as well as being important for risk of developing cancer. So ASCOT is again a brief intervention that is based on the habit-based model. We've taken the behaviours that the World Cancer Research Fund recommends. So they essentially recommend that people who've had a diagnosis of cancer follow the recommendations for prevention. And so again, we give advice on habit forming. It's all in a nice booklet, which you can link to that afterwards. You can see that. And there's quotes from patients and clinicians and self-monitoring sheets, action plan sheets that people can make their plans, tick off how they're doing, and self-monitor while they form their habits. And we've recruited over 1,000 people who had a diagnosis of either breast, prostate, or colorectal cancer. And again, we're following them up for 2 years. And we're also accessing some of their, with their permission, obviously, their medical records to look at the impact on. So we're looking at whether it changes behaviour as our primary outcome, but we're also getting some data from medical records to look at how it impacts on more clinical outcomes.
Wow.
So yes, that is very exciting,
very impressive work. Where are you at with that?
So we are at the point where we're hoping to have the results early next year. So we've been finalizing the analysis plan with our statistician, we have now just finished data collection from the participants themselves. We need to get some of the we need to get the access to their data records to get those outcomes, and there's a lot of cleaning, and some of the data needs to be entered from surveys, etc. But yes, so we should have, so we probably not the 2-year results, but at least the sort of 3 and 6 month results in early next year, which would be really exciting. And one of the, I think we were really lucky with that study because it's all been done remotely from the off. So, we were still able to collect data despite the pandemic impacting, poor Pippa's been sort of sending out masses of things from her own home rather than being able to do it from the office. But because it had always been remote, we didn't have to sort of replan how we got that data, which was good. But it also meant we could do, because we had this large cohort of engaged participants, we added an extra follow-up, and so collected some data on their behaviours during the pandemic, and also did some interviews with them about the impact of the pandemic, which has been really interesting, because obviously there's been a lot of work on that, I think, in the general population, but this, is a group who, it's a different group in terms of having had cancer, and so
and living through that, historical period that we've all been in.
And one of the things that one of the things we've got a student who's about to start looking at the minute, which I think is really interesting, is, we talked about teachable moments earlier, and one of the things he's going to look at is when we recruited participants into ASCOT, we asked them, had their behaviours changed since their cancer diagnosis? Because again, that can be potentially a moment at which people decide, okay, I'm going to well, it can go in both ways. I think either I'm going to live super healthily from now on because I'm worried about, the fact that recurrence and all of those sorts of things, or, they go, well, I got cancer, and so now I'm just going to do whatever I like and not worry about that stuff. And I think in talking to participants, you get a real mix, but that COVID as well did cause some people to change their behaviours, and we've got that data as well. So we've got, did they change when they had a diagnosis of cancer, and how they responded to COVID. One of those is a much more personal experience, significant life event, whereas the other is a sort of bigger thing that was happening to everyone. So he's going to be looking at, did they respond in the same way, the same people, or did some, were there differences? And I think that's really, hopefully it'll be quite interesting.
We'll have to have you back, Rebecca, in a year's time. With lots of results from clearly quite a few ongoing trials.
We've got it's this approach is another one that Pippa and Abby are running at the minute. It's more physical activity focused, but looking at an app for introducing people to an app after a diagnosis of cancer, and so that we've started the pilot for that over the last year, and I've got, well, I say over the last year, it's really been over the last few months. So we've got 24. We've got 24 people last time I checked, recruited, because that's a Yorkshire-based study, so it's funded by Yorkshire Cancer Research, who also fund me and my time, and the fellowship that I got from them was the reason I moved to Leeds. So I think intervention development is so important, and I guess as a behavioural scientist, that is one of the things that I am really interested in and I get excited about. And actually at Leeds, it's recently a couple of colleagues, so Susan Richards and Amanda Farron, who's based in the trials unit at Leeds, have set up the Leeds unit of complex intervention development, which I'm part of. which is really focused on sort of, the methods around how we develop our interventions and doing that better. So I think that's, it's a really exciting initiative, and we're going to be starting to roll out some sort of courses and things in the future, which I think will be great. But so far we've had lots of seminars and lots of very geeky discussions about intervention development, which is
good. Keep us posted, because I'm sure that a lot of people are interested in having more information on how to develop interventions and what to do about it, and it's a complicated area.
It is, and and sort of how you capture it and how you evaluate, as I was saying about sort of checking whether your interventions are doing what you think they're doing, whether there are unintended consequences, all of those things. And I think historically there's been a lot of qualitative work, and that's really important, but something that the trials unit bring is also some sort of quantitative methods around how you can that you can use it in this sort of early phase work as well. So it's a really nice mixture of people who are qualitative, quantitative, all passionate about the area, and it's a nice thing to be involved with.
Great.
Yeah.
It's really amazing work what you've done, Becca, and I know firsthand how hard you work, and it's just really good to see it sort of give sort of fruit, basically, and to show the effects that these interventions have. This the behavior side of it just does help so much with all this sort of intervention. So thank you so much for for coming on the podcast, for talking about this. Just even me, it's got me sort of like all wound up thinking that, oh my God, now what can we do? I mean, we did a little intervention as well.
We did, the ATI, which has finally been published.
Finally,
yeah. So that's a really interesting one, because I think, and I sort of alluded to this a little bit when I was talking about Claire's work, but, there are individual differences, and we've got these interventions, and, but they'll work for some people some of the time, but I think it's, I think something I'm really interested in is, working out a bit better what works for whom and when, and how we can better tailor our interventions, and the when being, are there certain times when people might be more receptive to them? But with the ATI, so that was a tailored intervention based on all of the work you'd done around appetitive traits, and after the ABQ, yes. So after you developed the ABQ, which meant we could measure these specific traits in adults for the first time, developed an intervention to say, okay, if we can capture these traits, that's great, and that's interesting and important, and looking at how they track over the life course is great, but can we actually support people to manage them? Because I think one of the things that they're tied to people's genetic propensity for weight gain, and we know now that there is a genetic component to weight, and again, work that Jane did with Susie Meisel showed that contrary to what a lot of people think, that doesn't make them think, oh well, there's nothing I can do about it, but it just helps them to understand and to go, okay, there's a reason why this is hard. And the great thing about the appetitive traits is it then also helps people to understand how those genes might be making it harder in a more specific way. And so obviously the intervention you developed was then trying to come up with some strategies that might help them to manage those traits once we knew what they were for an individual. And I think
the behavioral strategies, according to each individual's specific profile, which is really, it's a really cool way of doing it. I really want to get my teeth into being able to do more work with that, now that I'm sort of based here in Mexico, because it just, plus culturally as well, what effect did they have over there? What effect would they have here, etc. And then how you use the ATI in so many, the ABQ in so many settings.
And there's I was talking to you before this call about how there's interest over here. We were contacted by someone working in tier 3 weight management services who wants to use the ABQ, and I think if we can better understand these traits, we can then better support people. But working out exactly what those strategies to manage them should be, and how to communicate those in a way that's effective. Obviously the ATI is the first step in doing that, and it had I think it was a small study but really positive feedback and results. I think building on that would be great.
So that's
very exciting. Lots still to do, Claudia.
You haven't got rid of me yet, Becca.
No, good.
I told you it was permanent. This has been a really lovely talk. It's just so interesting, so much done, so much work that you've done on intervention, not just habit-based, but, around that, behavioral based. And I really applaud you for the work that you carry on doing. And thank you so much for being here on the podcast. It's great.
Thank you for having me. It's been lovely to see you, and I'm so impressed with this podcast. It's the fact that you've set it up, and it's almost weekly, isn't it? It's how many guests have you had so far?
It's been weekly. We're just sort of starting this new sort of new section this year. Starting in 2022, and hopefully we can get a lot of people interested in this subject of appetite, behavior, weight management, interested to come on and talk about their work, because I think the podcast just gives the opportunity to be able to disseminate it in a different way. One thing is reading the paper, and the other one is getting to know, like I told you before we started taping, getting to know the person. It's like, look, Becca, she's a person. She's not just like the name on a paper. And I think, and to know how we all work and how we do all this work, and how it gets us all excited, hopefully gets other people excited as well to do more research. So thank you again.
Yes.
And to everybody who's shown up today, I just want to say, thank you again for coming on alimentosyemociones podcast, and please share this content, comment, sorry, my throat. Please share, and share the podcast, share the episode, past episodes, comment, and leave your comments. Maybe other podcasts you'd like me to do, or other people who you think would be interesting to to interview. Just contact me, and leave the little notification so that you can learn about the next episodes that are going to be coming up. And thank you. And I'm going to say what I say every time, we all continue to nourish each other. So thank you for being here. Bye bye. See you next time. Bye. Gracias por escuchar un episodio más de Alimentos y Emociones Podcast. No olvides dejar un comentario, suscribirte al canal y presionar el botón de notificaciones. Ayúdanos a crecer. Y recuerda, nos seguimos nutriendo.